Tonight we have a very special guest. It's Dr. Gabriel Danovitch. He's a distinguished emeritus professor in the Division of Nephrology
Yeah, that one's
and head of our transplant program, which he actually initiated and created and made it what it is today. And he's kindly agreed to join us tonight to give us an overview of the state of the art of kidney transplantation that you should be aware of, and also to address any questions you have. So, Gabe, thank you so much for joining tonight.
Oh, yeah, I'm happy to be here, and I wish I could meet the people on the call um, personally. I wonder whether or not um, we could just do questions and answers, but let me just give a little introduction. I've spent my career as a nephrologist, working with Dr. Kurtz and my colleagues. And indeed, most of my career as a nephrologist has been in the field of organ transplantation. It's a wide field. It's a fascinating field. It's been a field that, for me personally, has been a source of great gratification and fascination, not just because of the medical part of it, because the medical part of it is fascinating, but also the ethical part of it and the legal part of it and the public policy part of it, because organ transplantation is different from many other forms of medicine in that there are profound personal and ethical and sometimes religious issues that we have to address. It's gratifying also because of all the treatments that we have available for people with advanced kidney disease. It's the one that can bring people's lives closer to normality. It's not total normality in that people still have to take medications forever, and those medications, most of the time, people tolerate well, but sometimes there are side effects when you take powerful medicines. But transplantation can give people a full life. Just to give you an example, dialysis, different forms of dialysis, even when done well, give you approximately maybe 15 to 20% of what your full kidney function would be if you had normal kidneys. That 20%, 15, 20% is enough for people to survive and go about their lives. But it's not a full life because there's a price to pay for only having that level of kidney function. Whereas organ transplantation can give you, all being well, if the kidney works well, can give you maybe 60, 70% of your normal kidney function and basically give you a sense of normality. People tend to feel better, to have more energy. They don't feel so foggy. And in the best of circumstances, they go about their lives. They can have children, women can have babies. I mean, things are not so simple, but people can go about their lives in a positive way. The issue with transplants is, where does the transplant going to come from? And essentially, as you probably know, those of you listening, there are two options. There are transplants from dead people and transplants from live people. There's no question that a transplant from a living donor is the best option. Transplant living donor is the best option for a variety of reasons. One, the quality of the kidney tends to be better. The actual kidney you give to someone tends to be better because it's coming from someone who is in a tip-top health. Otherwise, they wouldn't be able to be a kidney donor to you. But the other issue is you don't have to wait that long to get that transplant if that person is available to you. And with any luck and planning, and if we know ahead, we can do what's called preemptive transplantation. That is, get a transplant done before someone needs to be on dialysis and have all the different procedures that are required to facilitate dialysis. In the absence, about a third of people who have end-stage renal disease end up getting a transplant from a living donor. I'll come back to that in a second. The remainder, just who don't have a potential living donor, have to wait for a transplant from a dead person, and you have to wait often a long time, and that waiting list varies considerably around the country. But in all of Southern California, I would say just about all of California, the waiting times are very long. I can tell you patients are waiting 7, 8, 9, 10 years. And it's hard because in those 10 years, they're waiting on dialysis. Stuff happens to them. Dialysis takes a toll on people over the years. So that by the time they come to get the transplant, they're not always in a condition where they can really enjoy the transplant. So if one can get a living donor transplant early, that's really the best possible option. One thing I do want to say that's very important, there have been some dramatic changes in living donor transplantation, but perhaps most important in the last 10 years has been this issue that we can talk about later of kidney exchange. When I first got into this business, if someone was the wrong, in quotation marks, the wrong blood type, or for some other reason they weren't matched, the transplant could not go forward. So people were regarded as not compatible. But nowadays, because we're able, for a variety of different manipulations, just about a person who is in tip-top health and motivated to be a donor can be considered as a donor and can donate to that individual who's in need, either directly or indirectly. So we can make that transplant happen, even though there may be some incompatibilities or in quotation marks, the wrong blood type. So these days, there's no wrong blood type. We can make it happen. And that's very important because people often have a misconception. Oh, I would love to donate to someone, but I can't because I've got the wrong blood type or something else like that. So that we can get around that. And that's really been a dramatic and very gratifying change in the last decade. Transplantation is, the actual surgery under most circumstances is I would say it's not minor surgery, but it's not massive surgery. It's halfway between minor surgery and massive surgery. It's well defined in the kind of transplant centers you're likely to go to. And this, of course, I would say about UCLA, but the same applies to other centers in California, to Cedars, USC. I could mention them all. The surgeons are very, very good. You'll be in good hands. The surgical operation, in most circumstances, is fairly standardized. And so the surgery itself is it's not a small surgery, but it's not an overwhelming surgery. And most people recover from the surgery quite quickly. And it's also, I should say, not a particularly painful surgery. I don't want to say it's pain-free, but it's not a particularly painful surgery. For the donor, and this is very important, for the donor, there's been a dramatic change, again, in the last decade or so. When I, again, first got into this, the surgery for the donor was really quite painful and difficult. There was quite a big scar on the side. The scar was often painful. Muscle had to be cut in order to get to the kidney. And people often took weeks before they could really get back to work. And sometimes people had pain that went on a long time. I think we probably underestimated the pain the donors had, and quite likely they were reluctant to talk about their pain because they were more concerned about their recipients. But now, I would say 100%, 99% of the donor surgeries are done what we call laparoscopically. They're done through tiny incisions in the belly, laparoscopically, and it's really quite remarkable that the donor is typically in hospital for one night, maybe 2 nights, and the recovery is dramatically quicker, and they're back on their feet, living their lives very, very quickly. The donation process is a very, very careful one. The donation process is designed to protect the interests of the donor, both from a direct health point of view, but from a holistic point of view in terms of their lives, to make sure that the donation will not harm them. And in fact, when all goes well, which it almost always does, the donors often end up with a feeling of grace, a feeling that they've done something marvelous. I call it a halo effect, because they get to see their loved one or another human being. Sometimes I don't even know that human being, but to know that another human being has gained life because of what they've done, it's a source of great gratification. In Hebrew, we call it a mitzvah, a blessing, because I tell people sometimes that when you're on birthday or Christmas or Hanukkah, whatever it is, when you give someone a gift, it's often, or you get a gift from someone, it's more gratifying sometimes to give a gift that you know is just spot on than the one that gets it. When you give a gift that you know, yeah, that's the gift, that really was good, there's a gratification to that gift. And that's true of donors. And almost always, donors feel well and have a sense of self-worth and gratification by the virtue of the donation. But the process is a very careful one, very careful one. We have to make sure that the donation is done freely, without pressure. They're not being pressured by family members or not being pressured by guilt, that they're doing this out of a sense of free will, that they're fully educated as to what's involved, either directly or indirectly, in the short term, in the long term. They need to know. And we need to know, the doctors need to know everything about them. The team, the team of doctors and nurses and staff and social workers and psychiatrists and surgeons who care for the donor are separate from the team that looks after the recipient. That's very important. It's actually legally we have to do it that way, but ethically it's the right way to do it, because we have to put the interests of the donor first. We have to make sure that we do right by that donor as an individual patient. And as we say, the donor has the right to be treated as a patient with their interests as a patient, no less than the recipient. So there's a separate team that looks after the donor, and the recipient team does not interfere with the decision-making about the donation. There may be coordination, but there's no interference. I can't be persuaded by the recipient team to do something to the donor that I don't feel or we don't feel comfortable with. The process is fairly standardized, education, different kind of testing. We can go into the details of exactly what the donation involves. But the fact is that the donors do very well, and they have excellent health, and can look forward to a full lifespan. There are occasional cases of impaired kidney function over time, but it's really uncommon, and we have every reason to be gratified with the outcome of kidney donors. From the medical point of view and from the holistic kind of life experience point of view. So there, I spent my life involved in organ transplantation. So I obviously feel that it's a wonderful field and it's very gratifying. We have challenges, of course, that things most of the time go smoothly. They don't always go smoothly. I can tell you that the outcome, and this is kind of just broad statistics, the broad statistics are that the success rates of kidney transplantation, and that's measured approximately at 2 years after the transplant, is over 90%, approximately 95% success rate. It's higher, a little bit higher with living donation than with deceased donation, but the success rates are excellent. Can you die after a kidney transplant? You could. The mortality rates are very small, a couple of percent. A lot depends on what the underlying condition of the patient is. Some patients come to transplant just with kidney disease, and they don't have other what we call comorbidities, other major problems. But some patients come to transplant with comorbidities. They may have been diabetic for a long time. They may have trouble with their feet. They may have trouble with their vision. They may have some heart disease. They may have other things that will impact their outcome. So it's very hard to generalize as to what the outcome will be, but the outcome in general terms is excellent. And we wouldn't be doing these transplants were it not for the fact that the outcome is excellent. I should also tell you that there is no, and that I think is very important, there is no procedure in medicine, and I can say this with confidence, that is so transparent and accessible to the general public as is organ transplantation. And this doesn't only apply to kidneys, also to liver and heart transplantation and pancreas transplantation. That is, everything we do has to be reported to the government, to the database. There is a branch of the CMS, that's the Medicare and the Department of Health and Health, DHHS, that's the Department of Health and Human Services, called OPTN, Organ Procurement and Transplant Network. You can look up the web address of www.optn.org, I think, or probably .gov, the Organ Procurement and Transplant Network. And also, there's an organization that is contracted by the OPTN that you'll hear about, called UNOS, United Network for Organ Sharing. You should know about UNOS, and you should look at the UNOS website. That's www.unos.org. And perhaps we can provide you, if you don't have them, Ira, we can perhaps provide the audience with these websites either separately or at the end of this so they have access to it. In those websites, first of all, there's a lot of education material, but you can look up the outcomes and results of every single program in the country. With a few flicks of your mouse, you can say what happens at UCLA, how many patients got transplanted, what are their results, how do their results compare to other places. There is a lot of information that's in a easily accessible form. It's transparent. There are no dark secrets. Everything is out there for people to see, so that you can feel comfortable that the system is fair and transparent. That transparency is absolutely critical for what I call public trust. It's absolutely essential for the whole organ transplant endeavor that the general public trust what we do, particularly in deceased organ transplantation, because taking organs from dead people, when people who have died suddenly and families have to face the fact that their loved one has died suddenly and is a potential donor, there are profound ethical and personal issues involved. There has to be trust that everything will be done properly, ethically, according to rules and regulations that have been evaluated and are totally and repeatedly updated to make sure that it's fair, that the allocation of kidneys is fair, that there's no favoritism, that there are rules whereby organs are allocated according to clear rules that everyone can see and evaluate. There's no cheating, there's no favoritism. You can't push someone forward. There's none of that. There's no nonsense. And I can say I've been working with the US system of organ transplantation for 40 years, and I think it's pretty marvelous. I can't say there's never been issues that need to be addressed, of course, but the system, I see it as fair and safe and honest, and I feel privileged to be part of it. So I can look at myself in the mirror in the morning. I see I'm getting older, my hair is getting grayer, but I can look at the system and feel comfortable. Look at myself that I'm working in a system that's fair and honest, and the patients are getting a good, fair throw of the dice. And so there, I think perhaps at this time I'll stop, and I look forward to taking questions. When I take questions, I can't really make personal recommendations to people about their medications. I can talk about in generalizations, but I'd be happy to take questions from you.
Thank you so much, Gabe, for just a wonderful talk. And I want to thank you personally for all the care you've given over the years and the lives you've saved. Amazing program you created here. And thank you for tonight. I thought perhaps I would start by posing a few questions that come up pretty frequently at these talks. And one of them is there an age limit to transplantation at UCLA or other programs? What's the oldest patient that can get a kidney transplant?
That's a good question. So I'll talk about age with respect to recipients, and I'll also talk about it with respect to potential donors. There is no age limit, but the facts on the ground are such that once you get into the 70s, late 70s, a lot depends on the overall status of the patient. I think all of us know, just by looking around in our general lives and our family and friends, that there are 75-year-olds that act and look as if they're 85, and there's 75-year-olds that act and look as if they're 65, and there's 75-year-olds that act and look as if they're 75. So there's no age limit. At UCLA and at other places, we have transplanted patients as old as the early 80s. But it's a minority of dialysis patients in that situation. And those are patients in the early 80s who are in good shape, who, if you met them, you'd say, wow, you don't look as if you're 81, 82. You're functioning like someone who is considered to be younger. We talk about biologic age as opposed to chronologic age. That's why I don't want to give a fixed number, because people are different. We know that among ourselves. And there are sometimes 50-year-olds who are as if they were 80 years old. So it's a matter of taking a look at the whole patient. That's why it's so important, by the way, let me say this, because Ira, you work with dialysis patients far more than I do. For dialysis patients and people who are on the waiting list for transplant, to remain physically active. It's so important to walk, to keep active, not to be sedentary, not to be couch potatoes, to do their best to remain active lives. People who are on the waiting list for transplant have to see themselves as being I tell people, if you have to, in training for a marathon or for a 10K, you don't go for a 10K or a 5K or whatever. You don't just do it. If you just get up from your couch and do a 10K, you're going to crap out after the first corner. You have to go into training. So I tell people who are waiting for a transplant, no matter how long, keep active. Go for walks. Even if you don't feel like it, go for a walk. Keep active. Try to keep active also physically, also socially, and also cognitively, the most you can. It's not easy. I'm not saying it's easy, because life on dialysis can be hard. But if you're a transplant candidate, you have to keep yourself in good shape, so that when you get that transplant, you'll have an easy ride and you'll gain from the transplant. So that's age in terms of the recipients. In terms of the donors, that's also variable. There was a time when I again started in this business, then we would be reluctant to take someone over the mid-60s as donors. But now we are taking potential donors into the early 70s. Again, a lot depends on the overall health of that donor. As you know, Ira, under normal circumstances, in normal aging, there is some deterioration of kidney function in normal aging. So that as you get older, once you get into the late 70s, there may be reasons why it's not a good idea to be a donor. Although we have at UCLA taken donors in their early 70s. that's about more or less where it goes. There are places in the country that have taken donors that are older than that.
Thank you.
And in terms of, by the way, age, in terms of young age, according to the law, you can take donors over the age of 18. I'm quite uncomfortable about taking donors who are very young, unless there are exceptional circumstances. Because of one, as I said, someone told me yesterday, I was in a meeting with neuroscientists yesterday by chance, that the human brain is not fully formed. It is not fully formed until the early 20s. So that your decision-making capacity and maturity reaches its basically baseline in your early 20s. It's a big decision to make. And a lot depends in young people on their families, their ethnicity, their risk of diabetes. So with young people, we have to be particularly careful, because young people have, all being well, another 50 years of life to live. So we have a long time ahead to look about what might happen to them.
Thank you, Gabe. Another question that often comes up is a patient who has a history of cancer. I had prostate cancer 3 years ago, and I've been cancer-free, or breast cancer.
Right.
What is the approach of the?
Yes, so that's very, very variable, because as you know, there are hundreds of different forms of cancer, and the attitude towards cancer has to be individualized. So if someone just had, as I have had, a couple of squamous cell cancers on my skin because I'm in the sun a lot, that's usually not a big deal. If someone's had a melanoma, that's something we have to take very, very seriously in terms of skin cancers. So garden variety basal cell and squamous cell cancers, those are generally not a problem as far as transplantation is concerned. But a melanoma, depending on how deep it was and what its grading was, again, it has to be individualized. It's very important. Now, certain cancers are generated, are made worse by transplantation, and certain cancers are not affected. Cancers that we'd be particularly concerned about would be lung cancer, breast cancer, colon cancer. As you know, breast cancer has many, many different stages, from the early, what we call DCIS, which is just kind of a precancerous lesion, that when you take it out, it's all over, to people who have metastatic breast cancer. Someone who's had metastatic breast cancer, you'd have to wait a long time to make sure that that cancer was all gone before you would consider them as a transplant candidate. So the issue with cancer is that it has to be individualized. And since every case is different, when we're faced with someone who has a cancer and we're not quite sure what should we do, we would generally turn to our oncology, our cancer doctor colleagues, to get their advice and consultation as to what is the risk of cancer. Now, I can tell you, apart from any people who don't have cancer, are there certain cancers that develop after transplantation that are increased by transplantation? And there are some, but interestingly enough, the common cancers, colon cancer, prostate cancer, breast cancer, lung cancer, the frequency is not increased by having a transplant. Skin cancer is increased after having a transplant, and having what we call dermatologic surveillance, having a skin doctor taking a good look at your skin, and you to self-examine your skin on a regular basis is part of our treatment. Certain lymphomas can be more common after transplantation, but most of the common cancers, I repeat, colon, breast, lung, prostate, are not increased. We do have to be very careful with gynecologic cancers, because many of the gynecologic cancers, particularly cervical cancer, vulvar cancer, are associated with viral infections, a virus called HPV, papillomavirus. And those cancers can be problematic after transplantation, can get worse. So for a woman having having a pap smear, making sure that they don't have active HPV infection is extremely important. Fortunately, now these days, as you know, we have a vaccine against HPV, and I absolutely encourage everyone who have young girls in their family for them to get that HPV vaccine, because that HPV vaccine can prevent cervical cancer, which is a curse when it happens. So that's a separate topic. But if you have young women in your family, grandchildren, children, whatever, get them that HPV vaccine. It's very effective and very important.
Thank you, Gabe. Another confusing topic that comes up at these sessions is the time component. Several different scenarios. You have a patient who's CKD stage 5, and they're told in half a year, let's say, they're going to possibly need dialysis. Should they try to delay that and get a transplant workup as quickly as possible, given it's hard to predict exactly when they'll need dialysis, or should they go on dialysis and then at a slower pace get worked up for the transplant? And then at the other end of the scale, when they're already CKD stage 5, let's say, at what EGFR, given it's not a precise measurement, although no matter how many times we say it, people think it's a rock solid measurement. At what EGFR should people, if possible, in the ideal world, get transplanted?
So, according to the national rules, excuse me, someone can be on the transplant waiting list. You can be on the transplant waiting list once your EGFR or any estimation of your GFR is under 20, mil per minute. That's just a number. But a lot depends, Ira, and to the audience, on the nature of the illness, because different forms of kidney disease tend to progress at different rates. So diabetic kidney disease tends to progress at a certain rate. Then there's polycystic kidney that may progress much slower. Interstitial kidney disease can go slower. So some patients, the progress will be slower, and some patients, the progress will be less. Generally speaking, we encourage people who know that they have progressive kidney disease, because a lot of people don't know they have progressive kidney disease. I don't know whether the audience here know, but about 40% of people in this country who present with kidney disease present needing dialysis. In other words, you missed the boat. They're on dialysis, or they present in an emergency room, or they present somewhere already in advanced kidney disease. So there's no time to wait. They're on dialysis already. But if you know you have kidney disease and it's been monitored, we would, generally speaking, the kind of overall rule is when your EGFR gets to below 20, we can begin the process of trying our best to get you a transplant before you need to start dialysis. Sometimes people will say, sometimes people on dialysis will say, oh, I don't want my sister or my wife or my child to be a donor. I'll wait a little while on dialysis and see how I feel, and then maybe I'll go to them. And that is a mistake. If you have a potential living donor, the quicker you do that living donation, the better. The quicker. And if you can do it before the transplant, that's before the dialysis, that's even better, because it's been shown that the benefit of living donor transplantation tends to diminish with time. And that is, if you've been on dialysis for 4 or 5 years, the transplant is likely to be less beneficial than if you get it either just before dialysis or you've been on dialysis for a short period of time. So if there is a living donor and they are motivated to donate, don't tell them, let me see how I feel for a while, and then we'll do it. If they're available and they're motivated, then move ahead.
And by beneficial, you mean prolonging your life longer than...
Prolonging your life, because, the longer I don't have to say if there are people on dialysis in this audience, the longer you're on dialysis, the more likely you are to develop complications, to have heart disease, to other complications. So you want to try to transplant someone when they don't have a lot of what we call comorbidities. And the longer they are on dialysis, the more likely they are to develop issues. And they're getting older. I mean, that's just a fact. And I could probably fair to say that people age on dialysis more than they would age in normal healthy aging. Dialysis tends to age people. So I think that's all the more reason why you want to try to get it as early as possible.
And as you know, there's an increased incidence of coronary artery disease.
Yeah.
Acceleration
Yes.
on dialysis. Has anyone shown that once you get the transplant, your coronary arteries either stabilize or
Yeah, they do. They stabilize. They stabilize. We make a big fuss, and if anyone is in the audience here is on a transplant waiting list, just about everyone is assessed for potential for coronary artery disease. So we're always doing stress tests. We're looking out for coronary artery disease. We're very sensitive to coronary artery disease. And if you have coronary artery disease, it's far, far better to have a transplant than to be on dialysis.
and as you know, diabetes accounts for roughly half of the people on dialysis. Do you have strict criteria for someone's weight if they have type 2 diabetes or exercise tolerance? I mean, do you have any criteria that will determine whether you?
Well, wait. I'm glad you mentioned the issue of weight, because weight is important. If patients are really obese, you don't have to be a doctor to know that the transplant is going to be more difficult. The surgery is more difficult, and the benefits may be more difficult. So if patients are morbidly obese, massively obese, then that could be a problem, and it might be a reason why they should not be a potential kidney transplant candidate. Hang on, let me just get rid of this. Hang on. Lisa, I'm on a Zoom. I'll call you back in a minute. Thank you. Sorry about that. That's from the organ bank calling me. So who knows? Maybe someone's getting a transplant. A lot depends on where that obesity is. I don't know whether or not those of you might have read, there was a very interesting article, which you might want to look at, in the New York Times just last week on how we measure weight. You know, we use this term BMI, which you probably have heard of, which is a mixture of your height and your weight, is the BMI. But BMI doesn't tell you where the fat is. And you can have Shaquille O'Neal, who has a huge BMI, or you can have someone who has a belly, massive big belly with a huge BMI. So that's a problem with BMI. So now they're suggesting something called BRI, which basically you measure your circumference around your belly, because it's belly fat that is very, very important, because that's where the operation is. The operation is actually right. The kidney goes down there. So, and that's where people who are fat, that's where the fat is. So that can be a problem. So people who are what we call morbidly obese, or really obese, that can be an issue, and we have to evaluate them on an individual basis. I have a question here. Hello? I can't hear you.
You can unmute, Mary.
There you go.
Okay. Hi there. Dr.
What's your name?
I'm Mary Mormon, and I met you just before you retired.
Oh, right. I remember your face. Thank you. And who's that handsome guy next to you?
That handsome guy is my husband.
Oh, yeah?
Kerry, yes.
Your husband and your boyfriend, both of them together?
I put them all in one body.
Okay. All right. Nice to meet you.
Yeah, we were actually referred to you by my friend David, Dr. David Saya.
Oh, right. Yes.
A long time ago, in the beginning. And I started with complete kidney failure. I went from being healthy to no peeing I haven't peed for 2.5 years now. But what my issue is, and I'm really curious about this for you and what you have found, is that I now have, and I'm 5'7" and I'm 110 pounds. They've been doing paracentesis on me on a regular basis because I get a lot of fluid. I look like I'm either 7 to 9 months pregnant. So the paracentesis, UCLA have actually been going down to Westwood, and UCLA has been doing it. The last time they did it, they removed 3.7 liters, which is a lot of fluid for me. And they don't know yet. They thought it might be my liver. It's not my liver. My liver's good. They're going to check my heart. I need to see the Dr. Press, obviously, but I am just to a point where I'm starting to lose my positive outlook on life. I'm getting tired of dialysis. I'm getting tired of not only dialysis, but I spend so much time driving to LA or driving to Santa Clarita or driving to somewhere that's a UCLA. And I have to say, I really appreciate UCLA and the consistency and the communication and all of that is brilliant. But I'm losing my faith. I'm feeling a little deflated where, you know, in the beginning I was like, I'll get through this and I'll get a transplant. And I do have a donor who's gone this month. And I am going to talk to my son, who's 33. I've talked to him before, but that was 2.5 years ago. And a lot has changed, obviously, in that time. But I can feel what you're talking about as far as the dialysis taking its toll on me. This whole thing with my stomach, I feel like I just got into rhythm with dialysis, and now this paracentesis, I guess, is pretty common as you move along in the stages of kidney failure. But I still don't.
Let me say. So first of all, I'm sorry you're having a hard time.
Thank you.
I'm sorry you're having a hard time. I don't want to go into I can't go into the details of your case here, but I can tell you that you should not have a transplant before we understand why you're having that fluid in your belly. Okay. That has to be understood. We should not do a transplant while there's a process going on that we don't understand, that is not resolved. So, you know, that's gonna have to be resolved, and your nutritional status is gonna have to be resolved. So, you know, again, I can't go into the details, but it's absolutely critically important that be resolved before we would risk you having a transplant.
Okay. Well, they're doing everything. I mean, I've got my transplant team, and UCLA keeps me going with different doctors and different tests and all that stuff.
I understand. I wish you well, dear.
Thank you so much. I appreciate this very much. Thank you for doing this, for taking the time to do this. My pleasure.
Thank you, Mary, for that important question. Does anyone else have any questions for Dr. Danovitch? If you do, unmute. Brian, you have a...
Yes, I have a question.
Hello. Can I see your face? Can I see you? Hello?
Hello?
Yeah.
Yes. Now, you mentioned you would experience some...
What's your name, Brian? Brian, let me introduce yourself.
My name is Ed Washington.
Uh-huh.
And early in the presentation, you mentioned that possibly you could experience some pain regarding the transplant.
Mm-hmm.
Now, is that a removal of the existing kidneys, or do you keep your kidneys?
Yeah, I understand. Generally speaking, we do not remove the old kidneys when we do a transplant, because as I mentioned to you, the transplant doesn't go where the old kidneys are. So as I said, you know, your own kidneys are right here in your flank here, but the transplant doesn't go there. The transplant goes lower down. So unless there's a good reason to remove the old kidneys, we don't remove the old. They just stay there. And they just, we monitor them. We have to monitor them every now and again, but we just basically, most of the time, leave them alone and don't mess with them. And the transplant, therefore, is done here in your lower belly on the right side or on the left side. Generally speaking, on the right side, but there are reasons why it might be on the left side. Generally speaking, it's on the right side. And because of that, and because of where it is, it's not a particularly painful procedure. I mean, no surgical procedure is pain-free, but as surgical procedures go, it's not particularly painful. And because there's not a lot of muscle cutting, and it's not a particularly painful procedure. So that's not a big deal. And I mean, we have to, the first few days, people are taking medications for pain. Some people hardly need any medications for pain. People are different. But as surgical procedures go, it's not a particularly painful one.
Thank you.
Any other questions at all? Perhaps, Gabe, I could interject with another question. As you know, in the news, there's been a lot of talk about xenografts or pig kidney transplants. Could you?
Yeah, I always used to say.
When you
I'll tell you a little story. That when my kids were small, we were in Italy on a vacation, and in Rome, and the kids wanted pizza. Kids always want pizza. So I told them, there's pizza around the corner. There's pizza around the corner. We go around the corner, there was no pizza. We go around the next corner, there was no pizza. Where's the pizza? Daddy, where's the pizza? There's no pizza. Pizza's always around the corner. So I use that analogy because I always used to say that xenograft, that is kidneys coming from a different animal, and for a variety of reasons, it's likely to be the pig, it's always going to be around the corner. It's always going to be around the corner. Well, for the first time in the last couple of years, there's a sense it may actually be around the corner. It may actually, now whether or not I'll see it in my professional lifetime or my biologic lifetime, I don't know. It's still really, really early. And so, although a lot of work is going into it, and I think one day there will be a time when you get kidneys out of the fridge. I mean, I'm just saying that there will be a time. Now, whether that's 5 years, I think unlikely. 5 years, unlikely. 10 years, who knows? 20 years, who knows? But it's not around the corner. It's still not there. So no one who's waiting for a transplant should think, oh, I'm going to wait till I get one of those pig ones. Don't. It's too far out. It's going to happen, but it's not realistic at this time.
Another question that comes up often is the progression of chronic kidney disease, especially with the new drugs that are out there,
yes,
totally revolutionizing nephrology. Do you think it will be feasible within the next 4 or 5 years to slow down the progression of CKD so much that transplantation because that will become...
Well, I think, Dr. Kurtz and I have been in this business for a long time. I'm a little bit older than Dr. Kurtz, not that much older than Dr. Kurtz, but we've been in this business for decades. And for decades, there was no real sense that we could alter in a significant fashion the progression of kidney disease. It was tended to progress. But I think there's a sense in the last 2 or 3 years that there are new drugs available that may be changing the picture that will slow. I don't think they'll stop, but may slow the progression of kidney disease in a significant fashion. So I think we're about to see, for the first time in a long time, a shift in that there are new drugs available that may significantly slow the progression of kidney disease. I don't think they're going to stop them. I don't think they're going to be able to reverse them necessarily, but I think they may be able to slow them. And that's very, very encouraging. And those same drugs we may be able to use in transplantation to help increase the length of life of a transplant too. So, there's what we call a paradigm shift. That is, we're about to see, I think, a change in the way in which we deal with chronic kidney disease, both in your own kidneys and in a transplant, that I think is positive. So I think that's very hopeful.
Yes, and that's an important point. Another common question or thought is that half of the patients with end-stage renal disease in general have type 2 diabetes. I mean, there is a component of type 1, but the type 2 diabetics, to a large extent, are people who are overweight, who are not looking after themselves as far as their blood pressure, in addition to weight, exercise, these sort of things. Could we be doing a lot more for the public in the United States preventatively to cut back on the incidence of obesity and diabetes?
Of course.
And what role do you think this would play as far as a percentage in decreasing the number of transplants needed.
Right. Well, you know, I felt for a long time that the waiting list for transplantation, the waiting time people have to wait, is a combination of supply and demand. So on the one hand, the demand for kidneys, for people who are in kidney failure, the demand for more transplants. On the other hand, the fact that kidney disease is like an iceberg. And what we see in the United States and all over the world is the tip of the iceberg. And that underneath the level of the sea level is a lot of kidney disease that's unrecognized because of diabetes and obesity and poorly treated hypertension. And yes, I think that a lot of the times the transplant community is kind of held responsible for getting enough kidneys for people. And yes, we need to work hard to do that. On the other hand, we can't be responsible for the fact that there's so much unrecognized kidney disease in the community. And we just have to look around and see the incidence of type 2 diabetes is so high, and obesity, and which is sometimes well treated, sometimes not treated. Now, you know, there may be some new treatments coming along that's going to change that paradigm. Obesity treatment is changing. These new medicines are having quite a dramatic effect. But yes, prevention.
Okay, I think we have time for one more question. If anyone has a question for Dr. Danovitch, please unmute your microphone.
Well, I wish you all well. And it's been a pleasure talking to you. I hope this has been helpful to you in some way. I want to thank Dr. Kurtz for pulling this off. And I wish you all well. I'm giving you a kind of a Zoom hug to all of you. I wish you well. Thank you.
Thanks, everybody. And thanks to you, Dr. Danovitch, for taking the time.
Thank you, Dr. D.
Who's that? Hey, come on.
Ron.
That's the team.
Yeah.
All right. Love you guys. Thank you for doing
very
this.
happy to see you, sir.
Thank you for doing this. Love you guys. Be well. All right. See you later. Bye.